Thank you for joining us this afternoon for Improving Healthcare Response to Hypertensive Disorders of Pregnancy. All attendees are muted upon entry. The chat function has been turned off for this session. Questions can be typed into the Q&A box and they will be addressed at the end if time allows. Both the slides and the recording of this session will be posted on the CMQCC website within 7 business days of this webinar. An evaluation survey link will be sent to all attendees within 24 hours, and we thank you in advance for your response. You're welcome to use any of the slides provided for educational purposes. If you modify or add a slide, please follow the guidelines for the logos. And we welcome your feedback and recommendations for improving the slide set. The slide set is considered an educational resource, but does not define the standard of care in California or elsewhere. Readers are advised to adapt the guidelines and resources based on their local facility's level of care and patient population served, and are also advised to not rely solely on the guidelines presented here. We do have some notes on terminology and how they are used, and these are included in the toolkit. We have some learning objectives for today: to know the impact of hypertensive disorders of pregnancy on morbidity and mortality, to define the current terminology and understand the updated diagnostic criteria, to describe the management guidelines, and to identify systems of support on your unit for women and families before, during, and after a severe experience. With that, I'd like to turn it over to Dr. Elliot Main, the CMQCC Medical Director. Elliot?
Thanks, Valerie. And again, welcome everyone. Next slide. I'd like to start with a few words about CMQCC. We are now in our 15th year with a mission to end preventable mortality, morbidity, and racial disparities in maternity care. From our outset, we've been tightly linked to and guided by our State Maternal Mortality Review Committee with the goal of turning our maternal mortality reviews into action. Consequently, we have focused our efforts on the most common preventable causes of maternal mortality and morbidity: hemorrhage, hypertension, sepsis, and high cesarean rates. Our approach combines quality improvement toolkits, multiple large-scale implementation collaboratives, partnerships with a long list of public and private organizations, all driven by a rapid cycle maternal data center. On the right side, you see the decline in maternal mortality rates in California, for which our efforts contributed. Not shown in this slide is the ongoing racial inequity, with Black maternal mortality rates 5 times higher than whites. As we move forward with the next generation of toolkits and collaboratives, we are embracing direct equity actions as an equal partner to clinical interventions. Today, we are honored to share a major revision to our hypertension and pregnancy toolkit. As always with CMQCC, everything that we produce is shared openly on our website, cmqcc.org. The toolkit is now up, and as Valerie said, the slide deck and webinar will follow in about a week's time. Next slide. I'd like to introduce the co-chairs of the Hypertension Task Force. The top 3, Maurice Druzin, Nancy Peterson, and Larry Shields, will be presenting the toolkit today. All are decorated veterans of national, state, and hospital preeclampsia improvement efforts. Next slide. The task force members are shown in this slide. We are honored to have an incredible cast of nurses, community members, persons with lived experience, as well as doctors representing obstetrics, maternal fetal medicine, and emergency medicine. Actually, I'd like to give a special shout out to Dr. Mark Meyer, who led our efforts to reach out to the emergency room. While there is a new chapter in the toolkit for the ED, we plan additional materials for that important group in the coming new year. Next. Now I'd like to turn it over to Dr. Druzin. Thank you.
Thank you, Elliot, and welcome everyone. Next. Maternal hypertension in the United States has been increasing over the last 2 decades, and that includes gestational hypertension, which is related to pregnancy, preeclampsia, which is unique to pregnancy, eclampsia, which is one of the most feared complications of preeclampsia, but also chronic hypertension, which is the presence of hypertension prior to pregnancy. Next slide. If you look at the pregnancy-related deaths by cause in California over the last 8 years, you can see that the top 4 causes of leading causes of death are cardiovascular disease, sepsis, hemorrhage, and hypertensive disorders of pregnancy. And in general, these causes of death have been present even prior to the 2008 timeframe. And these are things that we are working on. And as Elliot mentioned, hemorrhage and hypertensive disorders are 2 of the causes of maternal death that have the greatest preventability. Next slide. Next slide. So just a summary of changes from our Preeclampsia Toolkit, which was published in 2013, is we expanded the scope of this toolkit to address all hypertensive disorders of pregnancy, although we will not have time in this webinar to talk about management of chronic hypertension. We've also aligned with the American College of OBGYN's definition of severe hypertension, and we are going to talk about consideration of treatment at lower borderline values. And we will briefly mention the role of low-dose aspirin for prevention of preeclampsia, and there's a new nationwide approach to implementing the use of low-dose aspirin at a larger scale. And then most importantly, the long-term follow-up after hypertensive disorders of pregnancy, because we know that women who suffer hypertensive disorders of pregnancy will have a lifelong increased risk of cardiovascular disease. Next. The spectrum of hypertensive disorders of pregnancy is demonstrated in the right-hand side of the slide. And I think it's fair to say that it's very complicated, that there's multiple overlapping conditions, and that makes it more difficult for diagnosis and for management. So I think it's really important to recognize the fact that this is a common disorder, a deadly disorder, but it's not a simple disorder to both diagnose and treat. We have removed the old technology of severe or mild preeclampsia. We talk about preeclampsia with or without severe features. Another old term is toxemia of pregnancy, and another one is pregnancy-induced hypertension, and we've removed those from our diagnostic tables. Next slide. So if you want to bring it down to the 5 key elements, basically what we are looking to do is to recognize the symptoms and diagnose the hypertensive disorders of pregnancy and put them into the correct classification. Secondly, most importantly, is blood pressure control, because blood pressure control is the key to preventing stroke and mortality. Next in importance, almost equal in importance, is seizure prevention, because seizures do increase the risk of mortality. And number 4 is, of course, the ultimate cure is delivery, although it's not, you don't get cured completely, but it is the most important intervention towards cure. And the delivery should occur at 34 weeks in preeclampsia with severe features, and by 37 weeks in preeclampsia without severe features or gestational hypertension. And then importantly, again, careful postpartum surveillance. Next slide. So the 4 R's of quality improvement included in what's called the AIM safety bundle for severe hypertension are readiness, recognition and prevention, response, and reporting systems. And these are the basic elements of quality improvement. Next slide. In terms of readiness, we're going to talk about risk factors and implementation. Next. These are the risk factors for preeclampsia. And as you can see, there's a number of obstetrical conditions. Number 3, chronic hypertension is one of the most common predisposing factors to development of preeclampsia. A history of preeclampsia at the bottom of the left-hand column is a critically important one. And then on the right-hand side, you can see a number of other demographic factors that increase your risk of preeclampsia. What's been added recently by the American College of OBGYN is patients who've had assisted reproductive technology, IVF, and all the other procedures. and also those with obstructive sleep apnea. These are the risk factors for preeclampsia, and these are the ones that we would recommend. For example, a patient be placed on a low-dose aspirin after 12 weeks as a possible preventative measure. Next slide. So the Joint Commission has come up with maternal safety standards, and these can function as a bundled checklist to guide this toolkit's implementation. So these safety standards that you see from 1 through 6 are all going to be addressed in some fashion in the toolkit. Not all of them will be addressed in the webinar, but they are all being addressed in the toolkit, and therefore hopefully can assist you in implementing the Joint Commission standards for maternal safety. Next slide. And remember that implementations are not one-size-fits-all endeavor. As in the introductory slides was mentioned, that we are giving you an outline. It's not the standard of care. It is hopefully clinical guidelines that you can adapt to your own institution. And therefore, it's important to identify and optimize your resources, and also make sure that you do have a way of monitoring your data and monitoring your implementation so that you can correct things that may not be perfect at the first implementation. Next slide. And again, as Dr. Elliott-Main mentioned, we are really making a top priority the equity and targeting the racial disparities in the management of hypertensive disorders of pregnancy. Next slide. And I'm going to turn it over to our colleague, Nancy Peterson, who is a very experienced nurse and who was involved in both the first toolkit and in this toolkit and numerous other toolkits. Thank you.
Thank you very much, Maurice. So I'm going to be covering just a few things out of that recognition section domain today. And so I'm really going to start with accurate blood pressure measurement, because as you know, that is one of the most critical measurements that we need to take that will guide us really in the management decisions in order to really avoid either over or under treatment that leads to the adverse outcomes. There are a lot of, following the steps, we've expanded on really talking about some of the other options as far as taking blood pressures with different size cuffs and using the conical shaped cuffs. But I think the main issues are making sure that you are consistent, same arm, same position, correct cuff size. And if you are using, most hospitals do use automated blood pressure cuffs, but make sure that they're validated every 6 months. And if not, then you really should be not only take an automated blood pressure first with the automated device, and then follow that with a manual cuff to just make sure that it is validated and it's accurate within 8 millimeters of mercury. Next slide. This is actually our quality improvement slide that was based really on the PAMR results and looking at really the most commonly missed symptoms among the deaths to women from preeclampsia that you can see on the left-hand side. It's important to remember that, that staff really need to be educated on many of these signs and symptoms. Many of them are, again, dismissed because they're normal for pregnancy, but there are some also that they need to be thinking in the back of their mind that it may also be related to preeclampsia. And then the signs on the right side, the misdiagnosed, are really when they misdiagnosed them, these were the things that they basically diagnosed them with. Was a seizure disorder, gallstones, chronic hypertension, new onset asthma, and postpartum psychosis. Next slide. This is one of our new, we call it the PERT, but it's the preeclampsia early warning tool. And this is a new version for this toolkit. It's a shorter version, but it's really designed to help with identifying how to best proceed in the evaluation and treatment of preeclampsia. It's found in the appendix of the toolkit. And it's really, it's actually designed too so that you can laminate it, you can make badge cards with it, or laminate it and put it in your each of your rooms so that it's easy to access. We still have the longer version that was in version 1 of the toolkit that we've updated, but that one also is available. You can use them for drills, but they're really, really helpful. Next slide. And this is the important point to remember. 40% of patients with new onset hypertension or new onset proteinuria will go on to develop preeclampsia. So again, you need to do continued surveillance and be hypervigilant with, really recognizing this. So with that, I'm going to pass the baton to Dr. Shields.
Great, thanks, Nancy. Next slide. So consistent with the first toolkit, we wanted to make sure that the criteria that we have utilized in the toolkit is consistent with ACOG definition of gestational hypertension, preeclampsia. You can see here, these are simply straight out of the ACOG practice bulletin, and reminder that we have 3 methods of identifying proteinuria for these patients: 24-hour urine, which I think is used less frequently now, protein creatinine ratio, or dipstick. That also is a reminder that total protein in 24 hours has been eliminated as a criteria for severe preeclampsia with severe features or indication for delivery for quite some time now. Next slide. Laboratory assessments. Anybody presenting with suspected preeclampsia should have a thorough laboratory assessment looking for end organ damage, as this would place the patient into the severe category, and then based on gestational age, determination of how to move forward. But if they're abnormal, they're going to be delivered almost at any gestational age. And just as a reminder, we generally think of preeclampsia as our sort of number 1 item for abnormalities for people presenting with abdominal pain, but there are less common entities within the pregnant population. These tend to get confused sometimes with patients present to the emergency department, and as we'll outline later, close collaboration with your emergency department, your OU department is critical for managing these patients. Next slide. Preeclampsia with severe features is essentially these laboratory abnormalities or pulmonary function or subjective symptoms. The laboratory abnormalities are outlined here. Their definitions of abnormality is pretty straightforward. The subjective symptoms, I think, is very important. People presenting with new onset headache, particularly not responsive to medication therapy, and medication is really not a narcotic, but something like Tylenol. Those with new onset visual disturbances. And then, the diagnosis within the ACOG criteria is elevated blood pressure separated by 4 hours apart. But just as a reminder, unless hypertensive therapy is initiated prior to this time, and that's a really important element. So a patient that presents with a blood pressure of 165/115 should be, and it is verified on a subsequent blood pressure, usually within 15 minutes, that patient should be treated acutely and given a diagnosis of preeclampsia with severe features or severe gestational hypertension. Next slide. Chronic hypertension is pretty straightforward from ACOG, less than 20 weeks or persists postpartum. It's important to remember this population, as Dr. Druzin pointed out earlier, is at extremely high risk for development of superimposed preeclampsia. And so patients presenting with symptoms of elevated blood pressure need to be assessed thoroughly to make sure that they haven't developed superimposed preeclampsia. Next slide. The other spectrum is this, in this preeclampsia severe features group, is HELLP syndrome as well as eclampsia. And you can see they sort of go together. And it's important to remember that patients with HELLP syndrome may not have proteinuria and they may not have significant hypertension. Their hypertension is frequently in the sort of stage 1 hypertension range, the 130 to 140 group. And so again, if you suspect hypertension, or excuse me, or preeclampsia, and their lab values suggest HELLP syndrome, you should treat them the same as those with severe features, like you would if they had elevated blood pressure, with both medication if needed for hypertension, but magnesium sulfate as well. Next slide. The difficulty with HELP syndrome is that sometimes you get lulled into they're not that sick, but these patients are at markedly increased risk for placental abruption, renal failure, subcapsular hematoma, or liver rupture. Frequently have preterm deliveries depending on the presentation of gestational age, and at much higher risk for fetal or maternal mortality, and much higher risk for having recurrent preeclampsia in a subsequent pregnancy. Next slide. I'm going to turn it back over to Nancy.
Thank you, Larry. So you've seen this slide, we've talked about it. So if you haven't gotten it yet, we have it in here just to remind you that any severe range blood pressure greater than, systolic greater than 160 or diastolic greater than 110 with a confirmatory blood pressure within 15 minutes needs to be treated with one of the first line drugs within 30 to 60 minutes. Most hospitals today have med kits that are available that you can pull. So generally, most hospitals can get this in by 30 minutes, but definitely by 60. So the main message here is do not wait the 4 hours to make a diagnosis. This is a hypertensive emergency and should be treated no matter what diagnosis they have. So that's really a huge key in this toolkit and the focus that we are trying to get the message out. Next slide. This is a nice little clinical pearl that we had out. Controlling blood pressure is the optimal intervention to prevent deaths due to stroke in women with preeclampsia. And I know Maurice mentioned it earlier, and he's going to talk a little bit more about it in just a few slides. Next slide. This is one of our tables that we have. We've tried again to make things very simple. You can laminate this, put it in your med kit. So if somebody's really not that familiar or hasn't given one of these first line drugs in a while, they have everything they need to know right there. And there's also other tables and algorithms in the toolkit similar to this. Next slide. So this is one of our acute treatment algorithms, another one, which has on the right side of the slide, the treatment recommendations with all 3 first line meds there. And to follow it down, it tells you exactly how often you need to repeat blood pressure and what dosage you need to go up on in the next dose. But what I like about this one is on the left side, you'll see that light green box. Because one of the things we didn't have in the first toolkit is once you've reached target blood pressures, so anything between 130 to 50 over 80 over 100, there was really no guidance on how often you need to continue to monitor that patient. So now we have some guidelines about making sure that you're continuing to follow and assess and repeat blood pressures to make sure that they're remaining under target. Next slide. So now I'm going to turn it back over to Maurice. Thank you.
Thank you, Nancy. So to follow up on what Nancy just mentioned, as we know, the leading cause of maternal death in the United States and actually probably worldwide of patients with preeclampsia is hemorrhagic stroke. This is something that is devastating. And even if the patient does not suffer maternal death, there's often serious maternal morbidity. Dr. James Martin on the right-hand column, Dr. Martin is referenced there. And unfortunately, Dr. Martin, who was a pioneer in many of the hypertensive disorders of pregnancy management algorithms, recently just passed away, a great loss for all of us and for the medical community and for the world at large. Anyway, James Martin and his group have a series of 28 patients who had strokes. They didn't all die, but they all had strokes related to preeclampsia. And he pointed out in a very important paper that the systolic blood pressure of 160 or greater was one of the things that were present in almost all of the patients who had stroke. We used to concentrate on the diastolic blood pressures of 110 or greater, but in fact, the systolic blood pressures of greater than 160 were more predictive of stroke. So that has been adapted as one of the criteria clearly for treatment. As you see, that number appears everywhere, 160 or 110. Dr. Judy et al., doing a deep dive into our CMQCC database, we looked at the hypertension, the level of hypertension in women who had a stroke and who actually died. So maternal mortality from stroke and preeclampsia. So we looked at these two papers. And if you see on the right-hand side, there were two patients who basically suffered a stroke with blood pressures less than 160, systolic blood pressures less than 160, and there were 4 patients whose diastolic pressures were less than 110. So if you think about potential preventability, you've got 6 patients out of 54. You're talking about close to 11% in this series of patients who potentially could have been saved had you treated the blood pressures at a lower level. And of course, what is that level? And that is the discussion that we're going to have in a minute here. Next slide. About what do you do with these borderline severe range blood pressure recommendations? So we know that you must treat at 160 or 110, either or, 160 systolic or 110 diastolic sustained, which means in 15 minutes. However, if a patient is in the borderline range, which we've defined as 155 to 159 or 105 to 109, clearly they are at risk for either going towards the severe range, or maybe they are not as severe as the 160, but they are clearly in a transitional phase. So based on the data from the 2 studies that I've just quoted, where we potentially had an 11 to 12% preventability, we are proposing the following, that if a patient comes in with borderline blood pressures, that this patient be treated as though she is imminently going to have preeclampsia with severe features, physician notification, evaluation, continuous electronic fetal monitoring, because these blood pressures that are labile often lead to abruption. And so that's another very, very important consideration. And we recommend these patients be observed for a minimum of 24 to 48 hours with frequent vital sign assessment and serial assessment of serum labs. We also recommend to consider antihypertensive therapy and magnesium sulfate, although that is not the ACOG recommendation. And this is not something that we are putting out as a strong recommendation, but as a consideration. Next slide. Just to remind us all about magnesium sulfate. Magnesium sulfate is an anti-seizure medication and is indicated for seizure prophylaxis in all patients with preeclampsia with severe features, but also in patients with severe gestational hypertension, that's the 160, 110, who may not have true preeclampsia with proteinuria or end organ involvement, but we are talking about the blood pressure. So if a patient has severe gestational hypertension, she is to be treated exactly the same way as we do preeclampsia with severe features, with blood pressure control and with seizure prophylaxis. And again, if the patient has severe range blood pressures, as noted, 160 or 110 or greater, lasting 15 minutes or more, they need to be treated regardless on what you're calling their diagnosis. Now, the American College of OB/GYN has a statement that says magnesium sulfate is not universally recommended for preeclampsia without severe features. So it's not universally recommended, while patients with severe features, it is universally recommended. Next slide. Remember that magnesium sulfate is not an antihypertensive medication. We have all heard multiple times that the patient is getting MAG and her blood pressure went down, so we don't need to give them blood pressure medication, which is incorrect. So the primary effect of magnesium sulfate is via CNS depression, improves blood flow to the central nervous system, but essentially the blood pressure effect of magnesium is transient and is not significantly, it is not significant enough to be considered a true antihypertensive. So please remember that you must treat the hypertension with the appropriate antihypertensive drugs. Magnesium sulfate is purely used for its anti-seizure activity. Next slide. The most feared complication of the spectrum of disease is eclampsia, which is new onset seizures in the presence of preeclampsia. Fortunately, it's not common, but the mortality rate ranges from about 1% in the developed world, the United States, Europe, Australia, New Zealand, and others, but it may be as high as 15% in the developing world. So that is a staggering number for maternal mortality. Next slide. Remember that eclampsia is a severe form of preeclampsia, but the most common prodromal neurologic symptoms are headache and visual disturbance. And as Dr. Shields mentioned, those are two really important symptoms to take very seriously. However, 20% of patients with eclampsia actually reported no neurologic symptoms before the seizure. But anybody who presents with severe headache or visual disturbance has to be monitored very closely because they may actually be in the process of developing eclampsia. Next slide. I'm going to turn it back to Dr. Shields. Thank you.
Okay, thanks, Maury. So the other component that comes in is the patient presents prior to 34 weeks with severe either symptoms or severe range blood pressure, or does not have severe range blood pressures or severe features in the timing of delivery. And consistent with ACOG, the toolkit would recommend these patients be delivered either at or before 34 weeks, depending on the severity of their disease and stability, or at 37 weeks if they have a stable hypertensive disorder or pregnancy that without severe features. Next slide. And this is just sort of reiterating the same thing, that in patients with preterm preeclampsia with severe features, there can be rapid progression of this disease, and maternal morbidity and mortality is significantly increased in this population of patients. Next slide. But there are patients where consideration for expectant management is clinically indicated in patients presenting prior to 34 weeks. And these can be best described as patients where they have received blood pressure medication with good blood pressure control. They have initial seizure prophylaxis with magnesium sulfate, and then they have the absence of any sort of severe feature, which would be outlined here as subjective features. They have stable cardiopulmonary function, i.e. they don't have pulmonary edema or evidence of cardiac dysfunction. And these patients should then be allowed to gain gestational age with the treatment with corticosteroids for lung maturity with appropriate consultations. And they should probably be transferred to a level of care that can take care of the gestational age after initial stabilization. Next slide. Long-term, these patients are going to, if they present it, say at 28 weeks, ideally you want to get them to 34 weeks, they're going to have high risk for recurrence of their severe features or severe hypertension, development of laboratory abnormalities, symptoms of placental abruption, poor fetal growth or abnormal fetal testing. And any of these elements, depending on the severity, is going to be an indication for delivery of that patient prior to 34 weeks. And while you're trying to extend their gestational age, I think it's important to remember same thing Maurice saying is that the progression of the disease can be very quick, and the average length of time that you'll gain on these patients, although it's quite variable, is somewhere between the 7 to 10 day range. So it's not atypical if you admit somebody here at 28 weeks that you will not be delivering them at 34 weeks. Next slide. The other long-term component is that when patients go home after having a hypertensive disorder in pregnancy, it's very important that they receive clear educational materials outlining signs and symptoms that should alert them that further assessment is necessary either at their provider's office or more likely at the hospital. Ideally, patients should go home with a home blood pressure monitoring cuff so that they can be monitoring the blood pressures at home and then either reporting them when they get to some preset target value so outpatient management can be optimized, or they know when to come back to the hospital. Next slide. The Preeclampsia Foundation, who participated in the development of this toolkit, has a number of patient educational materials that are designed for a whole variety of literacy levels and medical literacy levels. And these are available through their website and really provide an excellent component that you could give your patients for when they go home postpartum or they've been admitted and allowed to go home after assessment for preeclampsia. Someone might have mild preeclampsia or preeclampsia without severe features. Next. This slide is, we showed earlier, and it is important to point out that in the hypertensive disorder of pregnancy group, as with the cardiovascular disease and sepsis group, a significant number of these patients present after 7 to 42 days. So these patients are most likely going to re-present to your emergency room. And as I mentioned earlier, having a really close collaboration with your emergency department and your obstetrical department for postpartum pregnancy is going to be critical for taking care of both the hypertensive patients as well as sepsis and cardiovascular disease. Next slide. Patients that go home have a significant risk of either a worsening of a disease, or they might have had, early stage 1 hypertension, and then they develop full-blown preeclampsia or severe gestational hypertension. Early discharge follow-up is critical in these patients. At least at our institution and a number of other ones within our system, readmission for hypertensive disorder of pregnancy has become the #1 cause for readmission of a recently delivered patient. So it's really important to identify these patients. The other long-term component that the patient needs to be aware of is their long-term cardiovascular risk. And this should be relayed to them so that they can then relay the information to their internist or family practitioner so that long-term cardiovascular health can be monitored for them as they go on in their life. Next slide. Late postpartum preeclampsia occurring 48 hours or up to 6 weeks accounts for about 26% of eclampsia cases. We've gotten very good at managing interpartum patients. Ideally, we can do better based on the mortality data. But a lot of these patients were presented, they had no antepartum diagnosis of hypertensive disorder of pregnancy, but they come back either with having a convulsion at home or, as Dr. Druzin pointed out, with the telltale signs of either visual or headache symptoms, which appears in about 70% of these patients. Other symptoms that may be present that suggest severe disease but may not be related to eclampsia are going to be shortness of breath, vomiting, other neurologic deficit or epigastric pain, which also is going to suggest severe disease, and acute intervention and admission to the hospital is going to be indicated. Next slide. So within the toolkit, there's a variety of clinical pearls. We've put them into the toolkit. This is another one of the clinical pearls that postpartum women who present to the emergency department and have a trigger, critical hypertension measurement or suspected preeclampsia should be assessed by and either admitted to the obstetrical service or a more appropriate place in the hospital, depending on the severity of their disease. Next slide. And as Dr. Main pointed out earlier, there was a lot of work done to try to improve the recognition and treatment of pregnant patient presenting to the emergency department with symptoms of preeclampsia. There's been a development of a flyer that's come to the front of the line. Patients need to be educated that if these signs or symptoms are present and they're either pregnant or recently pregnant, they should make sure that that's identified by the people that's triaging at the emergency room. And then both the emergency physician and OB should be made aware that the patient's arrival. And ideally, we should be teaching our patients to notify the hospital that they will be coming in so the appropriate services will be aware that they are coming soon. Next slide. Trigger blood pressures in the emergency department are the same as they are anyplace else. However, these are different than traditionally recognized as a critical blood pressure in a non-obstetrical patient. So education and collaboration with your emergency department is key for them recognizing the difference between a pregnant patient and a non-pregnant patient. And ideally, the EDs should be focusing on maternal resuscitation. They should be able to treat the blood pressure, start seizure prophylaxis while they're notifying their OB team, just like they would if they presented with similar symptoms on the labor and delivery floor or postpartum floor. Next slide. As I mentioned earlier, patients that have hypertensive disorder of pregnancy has been recognized now that they have long-term risk of cardiovascular dysfunction, particularly development of cardiomyopathy and pulmonary edema. These can present in the immediate 6-week postpartum period, or sometimes later, particularly for cardiomyopathy. So patients that have had a pregnancy, particularly within the last year, that present with shortness of breath or low oxygen saturation should be evaluated for cardiomyopathy. And then the internist or family practitioner should be aware of these risks for patient as they move on through their life. And other cardiovascular disease and monitoring should be taken out for those patients. Next slide. I'm going to turn it back over to Nancy Peterson.
Thank you, Larry. So as Larry just mentioned, it is so critically important that we do a better job with educating our patients about the signs and symptoms of preeclampsia, not only our, patients, but the families too. If you remember from our last toolkit, we discovered in doing the reviews of maternal deaths that delays in seeking care, as well as a lack of knowledge regarding signs and symptoms of preeclampsia, were the most frequently identified patient-related contributory factors in maternal deaths. So we really wanted to make sure that we cover a lot more material. And we also recognized that families were coming out and really, we realized that it didn't just impact once they were, better and they went on with their lives. It was a transformation, a vulnerable time for them. And some of them have never worked through that whole experience and really had some PTSD type symptoms. And so we added a lot of information in the toolkit about, just helping these women and supporting them through that vulnerable time and helping them to, get help with that. So there's a lot of information on this tool in this section of the toolkit that is really, really helpful to help our patients get through this. Next slide. As Maurice mentioned, we have added a section on the prevention of using low dose aspirin especially for those patients that have been identified as high risk in pregnancy or had preeclampsia with their last pregnancy, to prevent a reoccurrence of that. As you can see on the right side, this is one of the infographics that came from the Preeclampsia Foundation. I mean, they have so many wonderful tools there that you can go on and access, and they're free. And as Larry mentioned as well too, I think this is an area that is continuing to grow, and there's actually a March of Dimes toolkit that will be coming out later. But this is really an important one that we need to educate our patients. And it's just, we're recommending 81 milligrams per day prophylactically. So next slide. This slide is really from the United Preventative Services Task Force on aspirin use to prevent preeclampsia related morbidity and mortality. And it's actually a very nice clinical risk assessment tool, similar to the tools that we use in our toolkit for hemorrhage, where there's low, moderate, and high risk. And it gives you the ability to kind of see what category they're in, and then recommendations to initiate treatment based on their risk assessment. So that has been added to the toolkit as well. Next slide. Reporting covers really debriefs and case reviews and process measures. Go to the next slide, please. So you all know debriefs and case reviews are extremely important. Not only do they help us, learn kind of opportunities for improvement, but also identify system issues that we may have that we can fix, and hopefully that won't happen again. It also allows the team that were part of that event to share their perspective, because as you all know, when we have some of these events, we have a lot of multidisciplinary members of the team in the room, and we only see what we are a part of, and we miss what's going on in the room from somebody else's perspective. So debriefs are critically important. And then honing in and drilling down on some of the cases that, you could trying to get some more information and areas where we might have deficits that we can fix is really important. Plus, as we mentioned, the Joint Commission actually has debriefs as part of their elements of performance in their initiative. So it's also something that's required for severe preeclampsia that we do debriefs on those patients. Next slide. These are the process measure and outcome measures that we recommend. And one, of course, is timely treatment of hypertension. Again, it's so important that we're getting them treated as soon as that second confirmatory blood pressure has been confirmed, getting it treated within 30 to 60 minutes. And then the SMM, severe maternal mortality, at minimum is a good indicator for really doing a multidisciplinary case review. And so again, it's the AIM program and CMQCC use the CDC metric to track the rate of SMM complications in women. So it's a really good idea, since hopefully in your hospital there's a handful of them, to really go through and identify what some of the issues were so that you can hopefully improve. Next slide. And there we go. And I'm going to turn it over to Valerie.
Well, thank you everyone for presenting just the great presentations that were given. We're going to open it up to time for questions. And Christina Oldini, who has been helping us with the webinar, is going to moderate some of the questions for us.
Fabulous. Thank you, Dr. Valerie. For those of you that I don't know, I am an Associate Director of Programs out of CMQCC, and really thrilled with the amount and the quality of the questions that are coming in. So I'd love all our speakers to be on camera for the questions, and everyone looks like they are. So thank you guys. Let's get going. Maury, I'm going to start off with you. Great question. Do we really know anything more about what causes preeclampsia?
Well, we know that it's a placental disease. We know that it starts with poor implantation of the placenta. And basically, once that happens, all of the clinical sequelae of poor placentation occur. So it starts at implantation. We know that. What we don't know is how to make it better.
Thank you, Dr. Druzin. I'm trying to kind of put together all the questions here, and there are several. I want to, one of the first questions that came in, and I just want to clarify, we will be providing, but can one of you cite, there was a question about citing the maternal morbidity and mortality statistics for the risk-benefit determination to justify delivering at 34 weeks. Elliot, so that was for preeclampsia for severe features. Are you able to come off mute, Elliot?
Mortalities are rare, even among preeclampsia. So we don't break them down so much by gestational age, though we do know for sure that most of the mortalities happen in early onset disease, which is a much more severe disease than term disease. And that's true for baby morbidity, mortality, as well as mother maternal mortality. So you will not find in maternal mortality reports data that would definitively prove that, but all the clinical papers really point to early onset disease being the severest form of preeclampsia.
Thank you, Elliot. Valerie, can you bring up slide 41? I appreciate that. And I'd love Nancy to weigh in on this, and then maybe we get a physician or a provider perspective too on this. It's about the BP monitoring. I hear so many things. Take a BP within 15, at 15, Q5. It really makes it tough for the bedside nurse to be successful. A person said the box looks very difficult for nurses to be successful. Can you guys speak to that?
Well, let me take that first, and then I'll let Maury or Larry join in. We were really trying to be mindful of the fact that, yes, it is very difficult. And especially now when most hospitals are struggling with short staffing and, all the other issues going on. These are, really, if you can do it, I think the main message is do the best you can, but really don't, kind of let them go. I mean, what I've seen a lot of times is once they have gotten below threshold, they've given a dose or two of one of the first line drugs, and now they're below threshold, those blood pressures get spaced out, sometimes for hours. So these are, I know, very ambitious to say to try and do this every hour. And keep in mind too, that these patients should be 1-to-1, ideally 1-to-1 for nursing step. So if you can do that, there should be no reason why you can't do it. But on the other hand, we all know the bus unloads sometimes, and you have to do the best you can. So what I want you to do is just keep in mind that it's really important that you stay on top of them, that you continue to monitor them out for 4 hours. And as long as they stay under threshold during that time, then you can slowly start spacing those reassessments out. So we understand, and we're really trying not to make it sound like you have to do this, but that's really the recommendation. Anybody else want to weigh in on that?
Yeah, so I would comment in addition, Nancy, that, reminding people that while you're acutely treating, you're going down one of the columns of the various antihypertensive medicines, so labetalol or hydralazine or nifedipine, and you're not bouncing in between them, going back and forth. So they have pretty, they're pretty straightforward. Repeat in 10 minutes for all of the labetalol, and it's 20 minutes if it's nifedipine or hydralazine. And then, particularly for smaller hospitals where the frequency of needing this aggressive intervention to lower blood pressure is less common, these should be laminated and probably either outside of the labor rooms, and whether they're in little pods or little groups, or ideally actually in the room so the nurse has ready access to know what the frequencies should be. In the larger hospitals, I think most of the nurses know the algorithm, pretty much off the top of their head and aren't referring to these. But again, I want to, emphasize what you said in the green box to the left. You can't just forget the patient's blood pressure once you've got it down once, because the tendency is for those blood pressures are going to rise up again in most patients, and intervention with additional medication is going to be needed.
Thank you. Go ahead.
May I make just one point?
You bet.
I think the attitude to this has to be that this is your sickest patient with the highest risk of both maternal and fetal morbidity and mortality. So the one-to-one nursing that Nancy mentioned is important, of course, if you're constrained with your resources, but this is your sickest patient, and you should think about this as an ICU patient. And that's why it's so important to keep track of their blood pressures, because as Larry said, these are labile blood pressures, and every time they have a severe range pressure, puts them at risk of stroke, abruption, and death. So these are the most critically ill patients that you have, and you should consider this as being in the ICU.
Thank you, Dr. Druzin. Dr. Druzin, I've got a quick question here, and then Elliot, I think we're probably going to end up closing out with a couple of questions for you. Maury, what about you've got a patient in your ambulatory setting, in the office, the clinic. They've got a BP of over 160 of 110. Do you treat them before transporting?
That's an outstanding question. If you have oral nifedipine, and you've diagnosed the 160 over 110, you've confirmed it while you've called the hospital, called the ambulance, you should try and treat it. Obviously, it's not always going to be possible, but you should, because that level of blood pressure can definitely lead to stroke or death. And it really depends on your resources and how long it's going to take for the ambulance to get there. If it's going to take you an hour to transport this patient, you absolutely need to treat them.
Excellent. Thank you for that. And I just want to take a break and just say thank you to all our attendees. These questions are fabulous. And Valerie and I and the team will be working on producing some sort of written communication, perhaps, that we can put online to get to all the questions. Our two closing questions really are out of and relate to CMQCC. So Elliot, what's the standpoint of CMQCC regarding the re-administration of magnesium on a severe range hypertensive patient who's already received MAG prior? Can you come off mute, Elliot?
So that's less of a CMQCC question than one of our hypertensive questions. So Maurice should answer that.
Okay.
I'll be happy to answer that. So if a patient has been on MAG and has been discharged and comes back in with severe features, we recommend that you retreat them with MAG because the stroke risk has not gone away. The seizure risk has not gone away. And as you noted, there are numerous patients who develop late postpartum eclampsia. So I would absolutely recommend that those patients get another magnesium sulfate course. Now, you can argue maybe it's only 12 versus 24 hours, depending on how the patient is looking, but they definitely need to be treated with magnesium again.
Okay, final question, and I swear, Elliot, these were not planted questions. It's your opportunity really to highlight the work out of CMQCC. Talk to us about low-dose aspirin, what's going on, and a new endeavor that's going to be going on in the state.
We're very excited about partnering with the March of Dimes both nationally and statewide and with local community groups to really identify what the barriers are first for prescribing and taking low-dose aspirin, as well as what the appropriate messages should be. This is a simple medication, but there is a barrier for asking a woman to take it for an entire pregnancy, when on the other hand, we've been preaching not to take medications during pregnancy. But it is a very safe medicine, and it is something that can have a significant impact. So like with everything, it's about implementation of new guidelines. And that's something that we have a lot of experience with, but we're moving into now the outpatient arena, which is different than the hospital that we've been talking about for most of the seminar today. And that has new challenges that we are eager to embrace.
Wonderful. Everybody, on behalf of CMQCC, our partners, our stellar faculty today, we want to thank everybody for joining us. Please download the toolkit. It's available for you, including independent access to each of the appendices. A lot of work went into this stellar team, and we want to recognize everybody. So thank you, everybody, for joining us today. Have a wonderful Thanksgiving.
Thank you, everyone. Bye.
Thank you.